And I will just start with saying thank you for having invited me to this fantastic meeting, and also we are so pleased having had the visit to the Chalaram Diabetes Institute and really impressed by all the work that's done there. So thank you so much for inviting us to come. So I will talk about the clinical perspective of using CSII sensor combination in type 1 diabetes. And just to start with, I'm a pediatrician. I only work with pediatric patients, and I have to admit I only work with type 1 diabetes patients because that's the big issue in Sweden in the young persons. So my perspective in giving this talk will be from the childhood perspective and type 1 diabetes, of course. What you see here is our old hospital and the new one that we are presently moving into in Stockholm. So just as a background, a few words about diabetes in the young people in Sweden. We have, second to Finland, the highest incidence in the world of type 1 diabetes in young people or in people any ages. The incidence is almost 50 or 100,000 kids up to the age of 18. And about 25% of the kids that are diagnosed with type 1 diabetes are below, they are in preschool age. And it's not unusual at all in my clinic to have kids below the 1 years of age having been diagnosed with type 1 diabetes. We have a prevalence of almost 8,000 kids. 98% almost type 1 diabetes, and there are less than 100 kids or youngsters that have type 2 diabetes in Sweden today. In my clinic, which is the largest in Scandinavia, we take care of around 900 children with type 1 diabetes below the age of 18. At diagnosis, around 20% will be ketoacidotic. After diagnosis, the percentage of children having ketoacidosis when they are already in treatment is very low, around 0.6% each year. The IDF and ISPAD global guidelines for diabetes in childhood and adolescence, they grade the different kinds of care as recommended care, which would be evidence-based care, cost-effective in most nations, with a well-developed service base and with healthcare funding systems consuming a significant part of their national wealth. In contrast, or going upwards to comprehensive care, which is care with some evidence base that's provided in healthcare settings with considerable resources. And you have to bear this in mind when we discuss the CSII and the CGM revolution that is now taking part, I think. So what are then the goals for diabetes treatment in young people? Well, of course, normal growth and pubertal development, a low rate of acute complications, prevention of microvascular and cardiovascular complications, and an optimal social adjustment. So how could then CSII or CGM help reach these goals? Well, I'll start. First, I have to say I'm really happy about the first sessions this morning, the two first sessions that really gave a background to who should have or should everybody have and so on. I think I might say something about that at the end of when you hear our story. So if I ask my patients when they come back having started insulin pump, everyone will say no injections, that's the best thing. That's really the best thing. I don't have to do the pen. In Sweden we use insulin pens, but I don't have to do that. The parents will tell me this gives my child more stable glucose levels. It's much easier to correct hyperglycemia in between meals, during the night, evenings, or even, at the meals. You can give much smaller doses of insulin that are more precise. An insulin pen will give the smallest increment would be 0.5 units, and for very small children, that's too large increment. So it's really nice to have the very small doses, and also when adjusting the basal dose in those very small steps. And very many parents and kids that can say this themselves, they really appreciate the adjustable basal rate during the day. For example, doing physical activities to lower the basal rate a couple of hours before starting the physical activity will help them to lower the risk of hypoglycemia. On the more evidence-based perspective, we already heard this morning, it will lower HbA1c for a lot of patients, lower glucose variability, which is something that we are talking a lot more today. Higher health-related quality of life has been shown, and that's something which many teenagers will tell us, that this gives me a freedom that I didn't have before. There are very few, in our setting, there are very few patients who stop using the insulin pump and go back to MDI, multiple daily insulin injections. Most will stay on the insulin pump. They may change the kind of insulin pump and so on, going on, but very few stop using it. There are a few teenagers who want some bodily freedom, not having a technical thing on the body, but most will continue using the insulin pump. And there is evidence for lower risk for long-term complications. Why CGM then? Well, from the patient's perspective, the kids, no finger pricks, we just love it. For the parents and the older kids, they will say, I really appreciate the curve. I'm talking now about CGM real time. We really appreciate the glucose curve to look, in the retrospect, to see what has happened during the night, for example. Everybody loves the predictive arrows to see where is it going, where's my glucose going. And many patients' parents, I would say, really like the way to have the possibility to have a structured analysis of glucose data, either using a mobile app or using a computer program. I'll come back to that a little later. On the more evidence-based perspective, we see that the use of CGM will lower HbA1c, lower glucose variability, lower risk for hypo and hypoglycemia, and can prevent hypos due to unawareness, depending on what kind of CGM you're using. There is a very nice review recently in Diabetes Technology and Therapeutics that you can go through all this. So, what we are using, and which I have to say has been the big revolution, I think, I have worked with kids with diabetes, type 1 diabetes, for almost 30 years, having patients coming. Since we can't cure type 1 diabetes, which maybe we all of us hope we could, it's still, I think the CGM, the technical revolution, is really one of the best thing that's happened during my 30 years, and that's the last 2 years, I would say. The FGM, the flash glucose monitoring, Freestyle Libre Personal, was introduced in Sweden 2014, and it's been used widely. And still is, of course. And some of you may know, you flash the reader outside your clothes. You can do that many times. We recommend at least 10 times a day. And then you get the arrow, you get the value, of course, and you get the curve for 8 hours back, which gives you a lot of information on how to go on with your treatment. The CGM, real-time CGM in Sweden, we use it together with, of course, with the insulin pumps, with the Dexcom and the Guardian, the Medtronic systems. So I'll come back a little more to that. So then there is, of course, the question, who could benefit from the use of CGM or FGM, the flash glucose monitoring? We have had a lot of discussions on this and writing guidelines in Sweden. I have also to mention that all diabetes care and even also the technology is subsidized in Sweden for children and adults. So it's important that we have guidelines to who should be prescribed these different things, because because the patient doesn't have to pay for it, but still we need to know that we use it the best way. So we have discussions on type 1 diabetes, type 2 diabetes, and for the CGM, the type 1 diabetes in children, everybody is offered some kind of CGM, either flash glucose monitoring or CGM, if smaller children in need of alarms, or maybe hypoglycemia unawareness, which is kind of unusual in children, but still, then you will have the alarms. The clinics treating adult type 1s have been a little more reluctant to offer everybody, but now I think the guidelines are about to state that the type 1 patients will be offered at least the Freestyle Libre, the flash glucose monitoring. Type 2 has very recently, type 2's insulin treated with MDI treatment, multiple daily injection treatment, could also be offered at least the flash glucose monitoring. So then is the question, what should you measure as a clinical outcome when using this advanced technology? So of course HbA1c is one of those. We are looking now very much into, since going from handwritten diaries, charts, which the patient would jot down the value they had. We are going into, looking at glucose, the continuous glucose monitoring all the time with lots of more data. So we are looking into, looking at mean glucose for the last 14 days, for example, for patients, looking at that and following that to know if they are on the right track. We're looking at glucose variability. We're looking at time in range. And also time below 70, which will be very important for the young children, important for everybody. But really, we want as little time as possible in the low range, of course. And the analysis is done by the patient or the caregiver in a monitor, in the scanner, in the reader, in an app on a mobile or in the computer, and of course also done when they come to the doctor's, the diabetes team's office. So then we go on to the combination. We have the open loop, which of course is the most common still, with the CGM together with the CSII or MDI treatment. We have, when you can use either CGM or flash glucose monitoring, which then is a type of CGM. Or the threshold low glucose suspend of insulin infusion, the VO pump, as a type of closed loop, or the predictive low glucose suspend of insulin infusion with the Minimed 640G pump, which is the one that's on the market in Sweden today. Upcoming are the hybrid closed-loop systems with user adjustment of pre-meal boluses, full closed-loop systems with insulin only, or dual hormone closed-loop systems, but we don't have those, of course, on the market yet. The hybrid closed-loop is coming with the treat-to-target model. It's launched in US, but not in Europe. So this is what the semi-closed loop with Minimed 640G looks like, which we are now using quite a lot in Sweden, in children and in adults. You have the CGM, you have the insulin infusion set. See, there you go. You've got the pump, and you've got a blood glucose meter for calibration of the CGM and for measuring blood glucose before bolusing. But the really interesting thing is this with the insulin suspend before low, which is before we had, well, the first version, the VO pump would turn off the insulin, the basal infusion, at a set low level. Now this new pump, or fairly new, 640G, will turn off when the software calculates that within a certain time this person will be low. So I'll turn off the basal here, and I put it on again when the risk is over for hypoglycemia. So this is, it's really exciting to see how this works and how you can use this, all this new technology. So what is then successful and safe use of CGII and CGM? Well, you really, like the speakers this morning said, need to have a lot of knowledge about what the pump can do and what the pump cannot do. It's really important, and you need to have I think, fairly large number of hours of education for children, adults, parents, and other caregivers that you're going to use. You need to know how to dose insulin for meals, and in Sweden today, carb counting is used both for MDI patients and in pump users, almost always. How to correct hypoglycemia with the pump, of course, how to use the bolus calculator program in the pump. We also we want the patients to know how to treat hypoglycemia in a standardized way with dextrose, 3 grams per 10 kilos of body weight, and really, so it have a standardized way, not just take something to eat, because that will obviously lead to rebound phenomenon very quickly. And of course, how to calibrate the sensor. There are a lot of little things you have to do to wear a pump and a sensor. There are a lot of practical things you need to work on. And the strategies in case of pump failure to prevent DKA. Because this is, it's deadly if you don't understand that my pump is not working. I'm vomiting. Oh, everybody has a gastroenteritis now, so that's my problem too. It's not. It might not be. If you're a diabetic, it might be ketoacidosis that's on its way up. So if you don't realize this, if you're not checking your blood glucose either by capillary or using your sensor, and if you're using a sensor, you still have to verify by using a capillary blood glucose if you're not feeling well. So it's really, really important to teach in the strategies. So ketone measuring at home, we think you need to have that, urine or blood, close follow-up step by step in the pump functions, and we work in a multi-professional diabetes team. Recently, Swedish practice, we have launched new guidelines national for the diabetes care in Sweden for children. And we have set a very low HbA1c goal, but the mean HbA1c goal in Swedish children today below the age of 18 is 56 millimolar per liter, which is very low. Of course, without severe and frequent hypos. Low glucose variability, hypoglycemia definition, and as low as possible at time. So today, or actually from our national register 2017, 85% of all diabetes children type 1 in Sweden use CGM of some kind, 85%. And 65% of all type 1 diabetes kids used insulin pump. So not even in Sweden 100%. So what you can use a lot of different, this is all new. If you compare to the handwritten diaries, you can use, I love this. You can really look at, this is 14 days back, a girl born to 2011. She's only had diabetes for quite a short time. She's on the Minimed 640G pump. She's got an HbA1c of 6.8%. And you can follow her target range is here. You see that she does have some problems here. She does have some hypos here, or risk of hypos, but very little below actually, even because she's got this pump that she has. This is another way, another program. If you're not using the Medtronic pumps, you can use, for example, this is Sally, a girl 10 years old. She's got diabetes since 3 years of age. She's got celiac disease, Dexcom G5. She's using an Omnipod patch pump, which is really popular in Sweden. She's got an HbA1c of 6.3. She's got very ambitious parents working all the time in adjusting. And this is using the glucodiescent program for downloading the pump and the sensor, her Dexcom. And this is using the ambulatory glucose profile for 14 days back. Just some more details. Now this is in millimolar per liter, so I'll just skip that, I think. Don't worry about the numbers, but just look at, this is another way of looking at 3 days. The blue is low, below the threshold of hypoglycemia. The red is above threshold, and the green is within target. So just as a glance, you'll get a very quick, to see where you need to work and do something. So, of course, what we did, we reduced her basal before lunch. Of course, talked again about treating her hypos in a standardized way. Do not reduce the lunch dose if she's hypoglycemic, but treat the hypoglycemia and then give the lunch dose for the carbs that she's eating. We also talked about she's exercising a lot, so she needs to have a strategy to avoid hypoglycemia during exercise, of course. So with that, I'll just show you, that's my diabetes team, with all diabetes nurses, diabetes doctors, dietitians, social workers, and so on. And this is one of my patients. She actually had a tattoo made on her tummy. She's wearing an insulin pump. She says, diabetes, it can't beat me. It won't let me down. And let's hope that's what's going to happen. Thank you.
Thank you, Dr. Eva, for a very lucid and excellent presentation. Thank you very much. Actually, this system is very expensive in India. You get subsidized pumps and sensors in Sweden, but here it's a problem. It's very much poverty and everything is tremendous. Of course, we are blessed that type 1 diabetes is less in India, but still the problem is very high. Yes, questions?
Thank you. Hi, I'm Dr. Mittal from New Delhi. So these devices are now available in India, and we're actually using a lot of LibriPro and a fair amount of CGM. We've always been using Medtronic CGM, and now Dexcom is also beginning to sort of come in here. So the biggest question we have, I have two broad questions. One is, how do you choose which one to use? And we are using it a lot for type 2 also. We use it for type 1, of course, more, but since the sheer numbers of type 2 are huge, in terms of absolute numbers, type 2 usage is higher. So which one to use where? A, and B, do you have any experience or suggestions for the use in inpatient situations, in hospitalized situations? In hospitalized patients, patients who are hospitalized for monitoring continuously?
In our experience, very few kids are hospitalized after the diagnosis. So
not for type 1 necessarily, but any sick patient in the ward where you're trying to control.
Well, if they are on insulin pumps, is that your question? No.
Anybody, just for monitoring glucose. Patient is not on insulin pump, is on insulin infusion or sub-Q insulin or whatever in the ward, and you want a continuous glucose monitor.
Well, it's not that widely used yet for hospitalized patients, I can say, but I believe it's going to be more used, but I can't really answer your question because I would say that I would use CGM with alarms, I guess, which would be more, it's more accurate in that way, so you'll get that. I think your first question was, how do you choose which pump? Well, actually,
which pump?
Which pump to use?
No, which monitoring device to use?
We start with the flash glucose monitoring. It's cheaper in our setting, and it gives a lot of information, and usually the alarms are not needed. So we offer the flash glucose monitoring to all newly diagnosed patients in Sweden, in kids, if they're not very young, because then we'll use CGM instead, either the Dexcom system or the Medtronic system. So choosing different kinds of pumps is more a choice of the patient. Which kind of pump. Patch pump is very popular among teenagers, I can say. Yeah.
But between the different monitoring techniques or technologies available, is there something that drives you, other than patient choice and cost, is there something technically different that would lead you to choose one over the other? Because costs are very different.
Yeah, of course we want to have, the techniques with the lowest MARD, and good MARD and things like that. No, I think it's good for us and for the patients to have different choices to choose among, and a little different, some will need. There are upcoming CGMs that don't need calibrations, for example, that will be very much appreciated. And so that's one coming fairly soon, actually. So that's the thing.
Thank you.
Yeah.
Thank you very much.
Sir, you want to ask like a question?
Yes. This is Andy Basu from University of Virginia. I can probably answer, or try to answer both of Dr. Mittle's question regarding the use of CGM, or continuous glucose sensor in the hospital. As you know, in the US, it is not approved yet, but there are diabetologists at Emory, that is Guillermo Ampere's group, has published some studies of the use of CGM in the hospital. At the University of Virginia, I'm trying to spearhead the effort to use CGM in the intensive care unit as an adjunct to use of fingerstick glucoses or arterial. But certainly, those studies need to be done to see whether CGM use in the hospitalized patient can replace the use of self-monitoring of blood glucose or glucose monitoring. But again, those studies need to be done because as you know, there are some medications that are used in the hospitalized patients that can interfere with CGM signals. So again, those studies need to be done. As far as the use of flash glucose monitoring versus the Dexcom, again, it's 6 of one, half a dozen of another. Flash glucose is much more user-friendly compared to the Dexcom. And of course, as you know, flash glucose does not need calibration. But the next generation Dexcom CGM, that is G6, that they are hopefully, if they're going to approve later this year, will also not require calibration. So again, this is patient choice as well as what you're going to use it for. Thank you.
Thank you very much. I think all good things should come to an end. I thank the speaker and the organizers for arranging such a nice topic. Thank you very much.
Thank you, ma'am. Thank you, sir.